Dear students of the fifth year, good day. I'm Dr. Sherko. I hope good health for you and your families while you are staying home. So this is our first online lecture and the fifth lecture among the lectures of the nose and paranasal sinuses. The present lecture is about the commonest symptom or sign related to pathology in the nose and paranasal sinuses. And this symptoms is nasal obstruction or blocked nose. The blocked nose is the sensation, or it is a subjective sensation, of reduced airflow through the nose and can be bilateral or unilateral. And as we said that this symptom is the commonest symptom of the pathology in this area. Perhaps for better understanding, we might need a short review on the anatomy of the nose and paranasal sinus, especially the nasal cavity. And as you see in the picture on the left side, this is the external nose, which is composed of bony and cartilaginous part. The cartilaginous part, as we previously discussed, it's composed of two main cartilages, which is the upper and lower lateral cartilage. The lower lateral cartilages consist of two cruri, the lateral and the medial cruri. The vestibule, which is interiorly surrounded by hair follicle, is considered to be also a part of the external nose. On the right side of the picture of the right side shows the nasal cavity, and the anterior boundary of the nasal cavity is composed of anterior nares, and the posterior boundary is composed of posterior nares. In between there is nasal cavity, which contains three turbinates: inferior, middle, and superior turbinate. Nasal cavity is divided into two parts, right and left, by the septum. So the nasal cavity is composed of floor, which is mainly formed by the bone, the palatine bone, and the perpendicular and the horizontal plate of the palatine bone. Medially, the septum, which might be anteriorly cartilage, posteriorly is composed of two bones, vomer and perpendicular plate of ethmoid. Laterally, the lateral wall of the nasal cavity, as we said, contains three turbinates. Beneath each turbinate there is a meatus. So, the normal anatomy of the nose and paranasal sinuses, usually there might be some mild deviation of the septum or mild hypertrophy of the inferior or the turbinates, but this is usually not interfere with the normal nasal breathing. So this is the anatomy of the nose and nasal cavity especially. The current slide shows two pictures. The upper one is represent the normal nasal breathing, and the lower one represent the normal or abnormal mouth breathing. It means that mouth breathing might also be physiological or pathological. So, in normal respiration, the physiological pathway is via the nose, as shown in the upper picture. And the sensation of the nasal obstruction occurs when this process is impaired. If this severe, it means this obstruction is severe, mouth breathing will also be evident. In emergency situation and during extreme exercise, the higher ventilation requirements mean that physiological mouth breathing may also come into play. And as a necessary supplement to nasal respiration. Occasionally, athletes may become concerned about this and are best reassured that it is not unusual to have to resort to some mouth breathing during exercise. So, mouth breathing during emergency, during severe exercise, is considered to be physiological. Apart from exercise, there are other factors which might affect nasal respiration. So, normal physiological changes mean that nasal patency can be influenced by factors other than exercise, such as humidity, temperature, and the position of the body. Let's say in supine position, nose get more obstruction than the erect one. Regarding the difference of ventilation in both nasal and mouth breathing or respiration, the average rate of ventilation during nasal breathing at rest is approximately 6 liters per minute. However, during exercise, this rate will increase to 50 to 60 liters per minute. And we should remember that at this level, it will be shared jointly as nasal and mouth breathing. The area of internal nasal valve is a very significant and critical area in this topic. That's the nasal respiration. In the anatomy, internal nasal valve is located at the area of the lower border of the upper lateral cartilage, and it's considered to be the narrowest area in the respiration. So we have an area in which at the level of the lower border of the upper lateral cartilage, and as we see in the image in the slide, this area, the round dotted round area, is the internal nasal valve. This is the narrowest part, and the highest velocity of the flow occurs through this area, which is the narrowest point in the nasal area, in the nasal airway, as you said. Consequently, disorders acting to reduce the cross-sectional area in the nasal valve will have a major effect on the reduction of the nasal patency and increase the resistance to the air. It means that whenever you have some pathology in this area, even minor pathology will cause a high nasal obstruction. For example, if you have a minor septal deviation at this level, at this area, it will cause a big symptom considering obstruction. So, sensation of normal nasal flow. How we sense that there is a nasal flow, how we sense that the respiration is normal, there is no any nasal obstruction. Normally, when the air is going to enter the nasal cavity, it will touch the cool thermoreceptor, which is through the trigeminal nerve. It means that air will be in contact with these receptors, and there will be sensation of changing of temperature, cooling of the nasal cavity through the heat loss, heat exchange. So, how much the amount of this heat will be lost? It means that there is a huge contact between the air and these cool receptors, and it will lead to normal pattern of respirations. Otherwise, whenever there is some nasal obstruction, it means that the contact between the airflow and these receptors will decrease. It means that there is some problem in the nasal cavity leading to decreasing the contact between the flow and the receptors. For example, in case of nasal polyp or in case of septal deviation. So the contact decrease and leading to changing the pattern of the respiration. In that case, it will lead to hyperrespiration or hyperventilation. It means that if there is no pathology in the nasal cavity, it will be a normal pattern of respiration. Whenever there is a problem leading to nasal obstruction, it will lead to hyperventilation or increase the rate of respiration because of nasal obstruction. And of course, this is done by the connection between the thermoreceptors through the trigeminal nerve to the respiratory center in the brain. Another physiological process might also affect the nasal flow and leading to sensation of nasal obstruction, the so-called nasal cycle. This phenomena or this process might surprise most of the people that we are as humans usually breathe through one nostril all the time, from one nostril to another every 2.5 an hour, the so-called, as we said, nasal cycle. And it is under the control of autonomic sympathetic and parasympathetic nervous system and the hypothalamic control. This control will lead to congestion of the nasal mucosa of one side and decongestion of the contralateral side at the same time, leading to breathing through only one nostril. And usually this phenomenon or this process is unnoticeable. The human being cannot notice that he is breathing through one nostril. However, whenever there is some abnormality or some pathology, like for example infection in case of rhinitis, or hypertrophy of the turbinates in case of vasomotor rhinitis, the person will sense that there is obstruction of one side intermittently, going from one side to another. So nasal cycle might cause nasal obstruction, unilateral, intermittent unilateral nasal obstruction in special situations. About the etiology of nasal obstruction, it is useful to keep in mind the influence of patient's age, race, and geographic location. Starting from the congenital abnormality, which is usually more common in or become evident after birth, is conal atresia, which might be unilateral or bilateral, membranous, or bony, complete or incomplete. But whenever this is bilateral or complete atresia, no stenosis, it will be evident at birth, after birth immediately. Because neonates are obligatory nasal breather. He cannot breathe through the mouth. So the resultant posterior nasal airway obstruction causes a potentially life-threatening conditions. And this is very important to be diagnosed immediately after labor. When the child cannot breathe through the mouth, there is complete nasal obstruction and leading to severe cyanosis. And the best way as an urgent treatment is to insert an airway into the oral cavity. Another common cause of nasal obstruction, especially in child, is hypertrophy of the nasopharyngeal tonsil. That's to say adenoid hypertrophy. As you know that nasopharyngeal tonsil is a part of Walder's ring, which is a collection of lymphoid follicle, lymphoid tissue around the inlet of aerodigestive system. The function of this ring is protection and sampling, and usually the adenoid is large in child, and gradually with the time it becomes smaller, and it usually disappears after the age of 18. Whenever there is hypertrophy of the adenoid, it will lead to nasal obstruction because it is usually closed both posterior nares, and it will lead to mouth breathing, and it has developmental consequences leading to formation of adenoid face, such as pinched nostril, prominent central incisors, high arched palate, elongated face, hypoplastic maxilla. So adenoid is a common cause of nasal obstruction in child. There are other common conditions causing nasal obstruction. For example, in case of allergic rhinitis, which is more common in Western or European countries, leading to sneezing, watery rhinorrhea, and nasal obstruction. And as a consequence of allergic rhinitis, some patients will develop polyps, bilateral nasal polyps or unilateral nasal polyps, leading to nasal obstruction, valvular nasal obstruction. And sinusitis, infection of the paranasal sinuses, will also lead to mucosal edema and edema of the nasal mucosa, leading to sensation of nasal obstruction. Of course, tumors of the nose and paranasal sinuses, which is a space-occupying lesion or leading to obstruction as a mass obstructing the nasal airway, leading to nasal obstruction. Severe septal deviation, especially, will lead to even minor septal deviation if it is located at the area of the internal nasal valve, will lead to severe nasal obstruction. Some operations like rhinoplasty might lead to destruction of the nasal valve. That's the so-called collapse of nasal valve will also lead to nasal obstruction. Sometimes extensive septoplasty or extensive submucosal resection of the nasal septum will lead to flappy nasal septum, and it will lead to sensation of nasal obstruction during inspiration, because the negative pressure will lead to collapse of the nasal septum to touch the lateral wall, leading to nasal obstruction during inspiration. Apart from pathology of the nose and paranasal sinuses, diseases or pathology of the nasopharynx usually lead to nasal obstruction, as we discussed in case of adenoid hypertrophy, the mass occluding the nasopharynx, the quina, the posterior nasal opening, leading to also to nasal obstruction. But some patients usually the patient having more than one pathology. For example, having polyp or septal deviation together, sinusitis with allergic rhinitis, or adenoid hypertrophy with allergic rhinitis. So some patients having more than one pathology leading to nasal obstruction. How we evaluate and diagnose a patient with nasal obstruction? And it's clear, as we know, that the history is the foundation of evaluation. History is the cornerstone to approach the patient complaining from nasal obstruction. One should begin by characterizing the nature of the obstruction, taking into account the duration, periodicity, nocturnal variation, seasonal effect, laterality, association with the trauma, and any elevating or provoking factors. What we mean by this, for example, in case of, let us say, age, child, nasal obstruction in the newborn, usually we think about coronal atresia. Nasal obstruction in a child, we more think about nasal obstruction caused by hypertrophied adenoid. If it is associated with seasonal variation, for example, in spring, whenever there is the patient exposed to pollen, leading to obstruction and watery rhino and sneezing, we should think about allergy. Trauma. After trauma, we should think about septal deviation. Valvular nasal obstruction. That means that there is no nasal obstruction during inspiration, but there is obstruction with expiration. We should think about intraquinal polyp. If it is associated with nasal discharge, postnasal drip, we should think about sinusitis. If it's more common in the morning, associated with frontal headache, we should think about sinusitis, maxillary sinusitis. So history is the foundation of evaluation, foundation of diagnosis. We should approach meticulously with a detailed history of the feature of the nasal obstruction and associated symptoms, aggravating and relieving factors. After the history, we are going to examine the patient through clinical examination. Inspection of the external nose and the forehead and the area of the maxilla is important. So starting with the inspection to see whether there is any external nasal deviation in case of trauma, or elevated tip in case of pinched nostril in case of adenoid hypertrophy, adenoid face. As we said, hypoplastic maxilla, elongated face, prominent central incisor in case of adenoid hypertrophy. So inspection from outside is important. Then we are going to elevate the tip before insertion of nasal speculum, because sometimes insertion of the nasal speculum to see the anterior, to do anterior rhinoscopy, will obscure or hide some pathology in the nostril and the vestibule, especially the superior angle of the nostril. So elevate the tip to assess whether there is any caudal dislocation of the nasal septum before insertion of nasal speculum. After that, you are going to inspect the nasal cavity through the anterior nares by insertion of a nasal speculum to see the whole nasal cavity as much as possible. Assess the septum for any deviation. Assess the lateral wall for any turbinate hypertrophy. Assess the floor of the nasal cavity for any foreign body. Assess the whole nasal cavity for presence of any mass, such as polyp or tumor. Then examine the roof for any small polyp which might occupy the roof of the nasal cavity, leading to hyposmia in case of nasal polyp or allergy. Color of the mucosa is also important. Pale mucosa more goes with the allergic rhinitis. Congested red pink is more goes the infection, rhinitis and sinusitis. Sometimes hypertrophied inferior tenif is mauve-like a violet color. A deep red color more goes with vasomotor rhinitis. Then we are going to examine sometimes we use Cottle test to assess the anterior septal deviation. We are moving the skin of the cheek toward the laterally, and if there is improvement in breathing, it means that there is possibility of anterior septal deviation. Then after anterior rhinoscopy, we are going to examine the postnasal space through the postnasal mirror organ Carr speculum for any pathology which might located in the postnasal space leading to nasal obstruction. We can use fiberoptic nasopharyngoscopy to assess the whole nasal cavity and nasopharynx also. So clinical examination after history is the second stage for evaluation and diagnosis. In case of nasal obstruction, we usually reach the final diagnosis by a meticulous history and clinical examination. We need only investigations in case of uncertainty or to know the exact extent of the disease. Usually, we have rhinomanometry, which is a test of nasal flow that measures nasal resistance, the ratio between differential pressure and airflow. It offers an objective measure of the degree of impairment of nasal airflow. But unfortunately, in our locality, we are not practicing this investigation. Same for allergy test. Allergy test usually done in cases of nasal obstruction due to allergic rhinitis. But as we know that from the history and physical examination, the diagnosis of allergic rhinitis is straightforward. And usually allergy test is a prolonged test same in our locality, we are not performing this test in the diagnosis or evaluation of the allergic rhinitis. Other tests, like other investigations like X-ray, CT, and MRI, usually done to know the extent of the disease. Treatment of nasal obstruction depends on the diagnosis and the preference of the patient. Accordingly, with each diagnosis, we are going to plan for our treatment. For example, in case of choanal atresia, as we said, immediately after birth, the immediate treatment is to insert an airway into the oral cavity to separate the base of the tongue from the posterior pharyngeal wall to prevent suffocation and death in case of newborn. Same for the adenoid. We are going to follow the patient. If there is a hugely hypertrophied tonsil leading to total obstruction and interference with the sleeping, at that time we should think about operation. Otherwise, moderate or small size adenoid hypertrophy needs regular follow-up for a while before decision for an operation. In case of allergic rhinitis, we are going to instruct the patient for avoidance to allergen, which is the most single important measure in the treatment of allergic rhinitis. supplemented by medication like antihistamines and intranasal corticosteroids. In case of septal deviation, we should assess how much the septum is deviated. We have deviation, obstruction, and impaction. Usually deviations, minor deviation or moderate deviation do not need treatment. We might get benefit from some local decongestant, intranasal local decongestant like xylometazoline. And whenever there is total impaction of the septum leading to obstruction, severe obstruction, at that time you might go to the septoplasty. Same for other conditions like sinusitis or tumor. So accordingly, treatment of the nasal obstruction is according to the diagnosis.